So my topic is the prevention of surgical site infection in arthroplasty and what are the experts saying. Surgical site infection, defined by O'Grady and Baker, is usually an infection that occurs post-operative, increasing morbidity, mortality, hospital length of stay, and hospital admission. The textbook of medical and surgical nursing say the contribution of patients' natural skin flora and combination of surgical instruments, needles, dressings, attire, solutions, and human tissue connection cause increased risks. How do we prevent it? The World Health Organization 2002 identified practice for preventing SSI that consists of cleaning of the operating suite after procedures, the use of surgeon technique, sterile equipment, antibiotic prophylaxis, and preoperative preparation. O'Grady and Baker also put classifications of severity of SSI, so superficial, which includes the skin and subcut tissue, deep, which includes muscle layers, and the organ, which normally sits in the viscera or body cavities. A study conducted in 2013 looked at guidelines developed to prevent SSI over the past 15 years, and it was stated that orthopedic surgeons in this study suggested existing SSI prevention guidelines are used globally, but in relation to arthroplasty in particular, guidelines should be developed to create additional practice and raise issues or concerns and improve practice standard around the world. So a study done by Millarini, Zeng, and Graves 2013 suggests that sometimes guidelines can fail to prove health professionals with reflection of preference, and they can become outdated. And although results have been found that information obtained was crucial and beneficial in determining the most relevant and effective strategies used in our theatres today, it also shows that professional opinion varies. So, a cost-effectiveness prevention of SSI in arthroplasty in Australia was conducted by Millarini, Crawford, Whitehouse and Graves in 2013, and they came up with two strategies that both showed a substantial increase in deep SSI cases, resulting in higher mortality and higher costs. If these strategies were implemented, healthcare providers would absurdly incur costs to harm patients with SSI. So in 2013, a study survey was conducted by Riccardi, Bostrom, Lindgren, Ranstam, Millarini, and Dahl. And this is where they got evidence-based guidelines from around the world, including one Australian one, which was the Australian Guidelines for the Prevention and Control of Infection in Healthcare 2010. And results said that all the guidelines around the world proved the most preventative as well as effective strategies for surgical site infection, and these included preoperative showers, antibiotic prophylaxis, aseptic skin preparation for staff and patients, sterile gowning and gloving, monitoring of infection post-operative, and sterile dressings used within 24 to 48 hours. And ideally, these guidelines put out around the world should increase surgical outcomes and compromise patient morbidity. So Mellarini, Zeng, Graves, 2013 have also looked at a professional opinion, and they used methods of data collection to obtain results, and these were number one being review of guideline recommendations on SSI prevention in orthopedics, and this is where evidence discovered strategies for which infection rates increased, which was hair, jewelry, nail polish, and nasal decontamination. During the intraoperative phase, sterile gloves, gowns, and masks are enabled to maximize barrier precautions and reduce surgical site infections. Number two, interviews were established to ask orthopedic clinicians on current significance of these trends, and 75% of professionals suggested that antibiotic prophylaxis will give the majority of the result, as well as staff management and recording of infection rate. There was also a conduction of 82% prevention in sterile barrier precautions. Number three, being the survey of healthcare clinicians in rating the importance of these prevention methods. So the survey developed the highest rating of preoperative prevention as antibiotic prophylaxis, scoring at 3.9, with 100% clinicians stating that it is significant when surgery is performed and rating it as highly important. This was followed by aseptic skin preparation of a patient. Reaching a score of 3.8, and also hand decontamination of staff, which was reaching a score of 3.6. Surgical site prevention conducted by Mellarini, Crawford, White, and Graves 2018 looked at the analysis of cost-effective strategies that have seemed to reduce rates in SSI, focusing on arthroplastic surgery. It showed an increase and rise in pressure in healthcare facilities like hospitals to provide patients with the best care at low costs. Systematic reviews had been conducted to determine the effective prevention strategies in SSI and an individual undergoing certain procedures, although it is unclear which is the most effective and also cost-effective in Australia. So there are a number of methods used to obtain the required information on the cost-effectiveness analysis, this being choosing infection prevention strategies for evaluation, prevention strategies for evaluation, designing a decision model, and identifying parameters to inform model health states. So a substantial increase in deep SSI cases was presented with higher mortality and higher costs. These results also verified the cost-effectiveness of routinely administering preoperative antibiotic prophylaxis. Some challenges and implementations of research put into practice is bias, as healthcare professionals give their own opinion what preventative strategies are viewed as the most effective, and this can cause other healthcare professionals to unfollow policy and guidelines. Some implementation can be educational services like in-services, modules that are mandatory, and employment training. Another challenge is not enough sufficient evidence focusing on the arthroplasty surgery guidelines itself. So a way of implementing this into practice is improving guidelines for that, continuously gaining expert opinion, as well as other healthcare professionals, and obtaining statistical information in regards to infection rates. And the importance of the NH and MRC to put this statement out in 2010 was, there is a need to minimize risk of microbial contamination of the operating site from the environment. Although there is limited evidence concerning the use of dedicated non-sterile operating attire by general staff in the operating environment, it may contribute to minimizing operating environment contamination and reduce the risk of surgical site infection. And there are my references. Thank you.